Hi, everyone. Thanks so much for joining. We're going to give it just another minute or two to let everyone hop in, and then we'll get started. So thank you.
Excuse me.
All right. I think we will go ahead and get started. So welcome everyone to the 2021 Virtual SMA Conference. This is Jessica from Cure SMA's Family Support Department, and we thank you all so much for joining us for the Sleep Problems Seen in SMA session today. We are so grateful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies for their incredible support of this year's virtual SMA conference. Please note that all lines are muted during this session other than for the speakers. But if you do have any questions, you can find the chat conversation tab, and it's located on the right-hand side of your screen. Please use this to submit questions throughout the session using this feature, and then we'll have time for Q&A questions at the end, and we'll try to answer as many of these questions as we can. And now I would like to introduce our speaker, Dr. Kravitz with Duke University. Hello, Dr. Kravitz.
Hi, how's everyone doing out there? Okay. So, it's always weird doing Zoom calls from last year and this year. I was really looking forward to seeing everyone's smiling faces in Austin, Texas, but I guess we're going to have to wait one more year. So everyone, get your vaccination so we can all be together again in a happier, healthier place. So, excuse me, I'm going to talk about sleep today. I'm a pediatric pulmonologist, and I'm also a sleep physician. So taking care of kids and patients with neuromuscular weakness is my interest. And given how many sleep-related issues and breathing-related issues overlap, it's really a great field to be involved in. Just before we start, some conflict of interest. On the scientific advisory committee for Biogen, Avexis, and Synthera, which means I basically give them medical advice. But none of the talk that I'm going to give today will have any conflict of interest or any overlap with regards to their products. So the goals of this session is to understand what is normal sleep. Now, for those of you who've come to the breathing basics talks in the past, we've talked about airway clearance and we talked about ventilation and support. And I am going to talk a little bit about ventilation support, but I'm kind of using this hour to, 45 minutes, to do an overview of sleep and what a patient needs to know about sleep. And before you can understand what's wrong with sleep in SMA, you have to understand what's normal, what's right about sleep. We want to talk about behavioral problems that we see in kids with SMA and young adults. We're going to talk about sleep disordered breathing, which is also something we do talk about in our breathing basics talks. And you can refer back to any of the archived breathing basic talks to get some more details on this information if I only touch on it today. And then we're going to wrap up with talking about how these new disease-modifying therapies that have just come out in the last 4 to 5 years are affecting our management from a sleep perspective. So before you can know what's abnormal, you have to know what's normal sleep. So sleep is divided into sleep cycles. There's something that we call the homeostatic drive, which is basically means the more I'm up, the more tired I am, and the circadian sleep drives. We have to understand good sleep hygiene, which seems pretty common sense, but you'd be surprised how many of us Americans don't have the best sleep hygiene. And then really, at the end of the day, what is the right amount of sleep needed to keep anyone healthy, but especially our children and our patients or ourselves with SMA? So sleep cycles. As a sleep doc, I divide the world into 3 parts: awake, non-REM, and REM sleep. Well, I think we all know what awake is because I'm hoping that the 52 participants are all awake right now, but we will check in on that a little bit later in this talk. Sleep itself is divided into 2 parts, non-REM and REM sleep. REM, which is rapid eye movement sleep, is where we dream. Non-REM is the rest of it. And non-REM is divided into 3 stages. Excuse me, stage 1, which is a transition sleep between awake and really being asleep. Stage 2, where we spend the bulk of our night, and then slow wave sleep, which is that really deep sleep that you have. And you know what it is. You feel your body drift off, and it is really hard to wake you out of. That's slow wave sleep. And as you can see from these percentages, we spend about 3/4 of our nights in non-REM and 1/4 of our night in REM sleep, and about half the night overall in stage 2 and about 1/4 in stage 3 or slow wave sleep. So this is what a typical normal night's sleep consists of. Now, we go through something called sleep cycles. So when I'm seeing families, whether they have SMA or another neuromuscular or just in my sleep practice, I always ask parents what they know about sleep because I want to know where you guys are coming from. None of us sleep through the night. We go through sleep cycles where we cycle between stages 1, 2, and 3 of sleep, REM, and being awake. And we average in general about 4 to 5 to maybe 6 sleep cycles, each lasting approximately an hour and a half. What we see here on the slide is what's called a hypnogram. And this is from when the patient goes to bed and they got up, and this is for a typical 8-hour period. And there's several things I'd like you to take home from this slide. First of all, this is in terms of sleep depth. So obviously wake, stage W, is the lightest, you're awake. REM sleep is the next lightest. REM sleep is actually pretty shallow sleep, and it's very easy to wake somebody up out of a dream. And then we get into stage 1, 2, and then stage 3, which is that really hard sleep to wake you up with. What you can see, there's 2 things during this study. Well, 3 things. One is we have sleep cycles. So here's someone woke up after about an hour, about 3 hours of sleep, and then another couple hours later, and then woke up for the day. So they didn't just sleep through the night. The second thing is you can see that the dark bars, which are REM, they get longer and longer as the night goes on. So you have more of your REM sleep later at night. And then you can see at the bottom here, you have more of your deep sleep early on. So we go to sleep and we tend to have deep sleep early on, dream sleep later in the evening. As a sleep doc, I use that to help tell me what type of problems that your child might have. So for example, if a child is waking up with screaming and crying and it sounds like a nightmare, if it occurs early in the evening, in the first 3 or 4 hours, it's probably coming from non-REM sleep, and that might be a night terror. But if it's occurring later in the evening, it might be coming from REM sleep, and it might be a true nightmare. There's other things we take in the history to get a sense of this, but this is what you can expect in sleep. And now you can, when you know what type of sleep problems you have and where the different phases of sleep are, you can predict when your child may be potentially getting into trouble. This is another important curve to remember. The homeostatic and circadian sleep drives. So we have 2 sleep drives that help us fall asleep. Homeostatic is the straight line, and it's pretty straightforward. You wake up, hopefully, the most awake you're going to be, and as the day progresses, you get more tired, and it's linear in nature. Circadian sleep varies. You start off awake, and then you get a little more tired as the day goes on, but then you wake up again, and then you get more tired. And in the ideal world, your homeostatic drive peaks at the same time your circadian drive peaks. So that helps you fall asleep at night. Anything that shifts these curves around is going to give you sleep problems, in particular insomnia. So for example, if you're going up this curve and then you take a nap, you're going to slide back down it. You won't be as tired. So when it's time to go to bed, your circadian may be peaked, but your homeostatic's not there. So you may have trouble initiating sleep. For those of us who have teenagers, we all know that they are night owls. They want to stay up late. And that's because the circadian drive is shifted to the right, or it's delayed. And so their homeostatic drive says, well, I'm still getting more tired, but their circadian drive says, I'm not ready for bed yet. So they want to go to bed later. What I can tell you in my practice is, I see, in addition to neuromuscular, I see obstructive sleep apnea, I see insomnia of various types. And I've seen more insomnia in the last year during COVID and lockdown than I probably have in the previous year or 2 before that combined. And I think what's happened is our kids have gotten off their rhythm because they don't have to get up and go to school anymore because they would do Zoom school or do computer school or online school. So their rhythms are totally off. And as a result, they're going to bed late, they're waking up late. Their sleep problems are manifest. That really wasn't a problem while we were in lockdown, but fortunately, we're all coming out and we're getting back into the world. Kids are going back to school. Well, if they're going to bed at 2, 3 in the morning and getting up at noon, and now the school tells them they have to be there at 8 o'clock in the morning, you're going to have some problems. So we have to try and keep these curves in mind. And when I talk about some of the behavioral aspects of sleep, I want to refer back to this curve. So when it comes to behavioral sleep, the good news is kids with SMA have the same behavioral sleep problems that kids without SMA have. In other words, there's nothing unique about your child's SMA that's going to impact about their behavioral sleep. Now, they may have problems with sleep disorder breathing, which we're going to talk about later, but in terms of their ability to go to sleep and fall asleep, it's just like any other kid. So we apply regular behavioral strategies and whatnot to our children. We don't have to do special things because they have SMA. They're just another kid. And as parents and providers, what do we want to do? We want to keep your kids, the patients that we see with SMA, we want to normalize their life as best as possible so that they're living with SMA, not SMA defining their outcomes. So we want to keep things normal. So the most common problems I see in kids and kids with sleep SMA are sleep onset association disorder, limit setting disorder, and what I've already alluded to, delayed sleep phase syndrome in our teenagers. This would be like our type 2s and 3s. Sleep onset association disorder is that you associate something with sleep. Now, for a lot of my kids who don't have SMA, that may be having a teddy bear in the room or a blanket or a light on. And when they wake up at the end of a sleep cycle, if that comfort object is not there, they may have trouble reinitiating sleep because they associate sleep onset with that product. In kids with SMA and kids without SMA, another thing that happens is parents stay in the room and watch their children. Our kids have special needs, so we want to make sure that everything's good before they go to bed. And in and of itself, there's nothing wrong with that. But if your child associates your presence with their ability to relax and fall asleep, when you go to bed at night and then they wake up in the middle of the night at the end of a cycle and you're not there, what are they going to do? They're going to call for mom, they're going to call for dad. So we want to make sure that your kids are going to sleep and having good sleep hygiene, good sleep habits, so that you don't have to be there in the room to help reassure them and have them go back to bed. So we do a lot of extinction behavior to get parents out of the room before the kids fall asleep. Limit setting disorder is also called encores, which is for kids who don't have SMA. They might come out of the room going, I want a glass of water, I have to go to the bathroom, there's a monster under my bed, will you please check the bed one more time? Very normal developmental pediatric related sleep issues. Well, our SMA kids can't get out of bed and walk and call and come down and ask for this, but they can call us for help. I'm uncomfortable. I want water. I need to be repositioned. Please roll me. Please change my pillow. All very reasonable things to ask for in a child with SMA, but we don't want that to become a process that's preventing them from going to sleep. So what is our job as parents? We go in, make sure they're comfortable, and then we get out fast so that they learn that I'm not hanging out in the room with you. You've got to initiate your sleep, but I'll make sure you're comfortable. And the best you can do is make sure they're as comfortable as they can be before they fall asleep. Delayed sleep phase syndrome, again, I tend to see that in our SMA 2s and 3s who are older. They're teenagers just like any other teenager, and as a result, they want to go to bed late, they want to get up late. The man makes you work and come in at 7, 8 o'clock in the morning, and so you got to learn to follow in that schedule. If you're a morning person, it works out great. If you're a night owl like me, it's a bit of a trouble. We want to have good sleep habits, good sleep hygiene. Everyone knows what good hygiene is. We know body hygiene, you take a shower, you use soap, maybe deodorants. We have good dental hygiene, you brush your teeth twice a day and floss. What's good sleep hygiene? Well, it's pretty self-evident, but you'd be surprised how many people don't have it. First of all, you want to have a bedtime ritual. You want to go to bed at a fixed time. You want to have a ritual, brush your teeth, story time, whatever it is for you to work to go to bed. You want a consistent bedtime. If you're going to bed at 8 o'clock one night and 10 o'clock the next and 12 the next, you're not going to have good night's sleep. You want to have comfortable, proper sleeping conditions. Lights off or at least pretty dark. We don't want background noise. A little white noise isn't a bad thing, maybe some light music, but you don't want TV on. You don't want your iPod playing. You don't want loud music. You want quiet things that will be inducive to falling asleep. Regular wake up time. How many times have you told your children, just go to bed earlier, you won't be so tired the next day? Well, as you all know, it's very easy to keep somebody up who's tired, but it's impossible to make someone fall asleep when they're awake. So the way you set your clock for the day is not at night by going to bed earlier, it's by what time you get up. And we're going to talk in a little bit, I think in the next slide, about how to start the day right to have good sleep habits. You want to have a good diet. Limit your caffeine intake. If you're caffeine sensitive, don't have it after lunch. And remember, caffeine's just not colas and coffee, it's also chocolate. So keep that in mind. We want a good body weight. If you're too heavy or obese, that can impact on your sleep and give you poor quality sleep. Well, we want regular exercise, or in our case for our SMA patients, regular therapies to keep them healthy, keep the muscles from developing contractures and the like. But we want to do that in the morning rather than the evening. Exercise or stimulation wakes us up. It increases body temperature, which makes it harder to fall asleep. So you don't want to be doing your therapies, your stretches at bedtime. That would be something better done before dinner. Light is a very potent wake promoting agent. Light goes into our eyes, into our retinas, and stimulates chemicals in our optic nerve that goes to the brain. Those chemicals wake us up. Light wakes us up. So we want light in the morning, but we want less of it at night. And a lot of people say, well, doc, I use my iPhone, but I have a blue filter on it because blue light makes things worse. Well, yeah, but that light is still there in your face. So we want less light at night. So you want to have good sleep habits so you can have healthy sleep. So these are my 8 patented steps to good sleep hygiene. And this works for kids with SMA. It works for moms and dads. It works for siblings. You want a regular wake up time every morning. No sleeping in on weekends. And why do we sleep in on weekends? Because we're Americans and we're sleep deprived. So we make it up on the weekends. Not good sleep habits. If you're doing well during the day, you're getting enough sleep, you will not feel the need to sleep in on a weekend. So don't do it. Lots of bright light in the morning, open the shades, turn on the lights. When I used to wake up my daughter for high school, if she didn't get up herself, I would get up, I would turn on the light in the hall, I'd turn the light on in her bathroom, I'd knock on her door, and then turn on the light in her room to start getting the light in her to help wake her up. I talked a little bit about decreased consumption of caffeine, so we certainly don't want to be drinking a large liter of Coke before you go to bed. Don't take naps. I talked about that curve going up and down on the homeostatic drive. You don't want to reset that, so do not take naps, no matter how tired you are. That might be the night you want to go to bed early. Exercise and therapy is good, but do it earlier in the day, not within a couple hours of bedtime. Less light at night, and remember, electronics is not just the television, that iPhone. These things, they're devils. They help ruin sleep for people. Present company excluded, of course. Go to bed when you're tired, not at a fixed bedtime. So that's younger kids probably need a fixed bedtime, but older kids, if it's 9 o'clock and you're really not tired, you might want to stay up a little bit longer, but do something that's not going to stimulate you to want to keep you up. And ideally, if you're able to get out of bed, we don't want to associate the bed with bad mojo by having them, every time I go to bed, I get stressed, I'm not going to sleep. So if you can't fall asleep in 15 minutes, I tell my ambulatory patients to get out of bed, maybe read for a few minutes. In our kids with SMA, that may not be practical, but you may want to have a book at your night table that you can reach over and read, keep you busy for a little bit until you're ready to initiate sleep. So the table on the left shows about what the average amount of sleep is. But here's the question: how much sleep is really needed? And a good question to ask yourself or your child is, you're having enough sleep if you wake in the morning feeling refreshed. Now, we're all allowed to be tired for the first 2 or 3 minutes. That's called sleep inertia. But once you get up and get moving, within 5 minutes, you should be feeling like, yeah, I had a good night's sleep. If you're able to function during the day without the use of any stimulants such as coffee, this is water, but in general, coffee, you don't fall asleep when you're not stimulated. So one of the questions I always ask my parents is, does your child fall asleep when you're driving to clinic? If they fall asleep in the car, they're tired. They're going to need more sleep or better quality sleep. They don't need a nap. And when it's time to go to bed, they fall asleep in about 10 to 15 to 20 minutes, which is a normal sleep latency. Okay. So that kind of talks about behavioral sleep, quantity of sleep. Now I'm going to talk about quality of sleep. You can get 8 hours of sleep, but if it's bad quality, you're still going to be tired. So sleep disordered breathing is the thing that we deal with the most in our SMA clinics, our kids with obstructive apnea, hypoventilation, things like that. But also keep in mind patient comfort. And this is where we can work with our physical therapist. We want to have a good mattress, proper support, our kids placed well at night. I have a lot of kids who wear leg braces, and they say, I can't sleep with my leg braces. So I have, when I take them off, I sleep fine, but I'm really uncomfortable. So I have to work with physical therapy and orthopedics to try and find the most comfortable brace for them that can help them with their legs or with their scoliosis, but it's not going to impact on their sleep, or minimally so. If they're needing ongoing therapies, like in our SMA ones who are pretty complicated, if they're needing suctioning or tube feeding, if you're waking them up in the middle of the night to give them a tube feed or suction them, that's going to impact on their quality. So we want to do therapies that are going to try and minimize that. For the rest of this talk, I really want to just focus on sleep disordered breathing. So what are our goals for respiratory support? Well, first, we want to treat any underlying obstructive sleep apnea and or hypoventilation. This goes back to the basic breathing basic talks that you've seen in the past. We want to maintain normal oxygenation and carbon dioxide levels. We want to have good sleep so that we rest your respiratory muscles so you have more energy the next day, that you didn't waste a lot of poor quality sleep on trying to breathe. You want to be able to breathe comfortably. We want our chest wall and abdominal wall to be in sync. So when you're breathing like this. We don't want this. As ineffective breathing is not going to be as helpful. It won't be as restful. We want good chest wall expansion. For those of you who have the cough assist, you can use that to expand your chest while you're awake. But the BiPAP devices we use, the non-invasive ventilation devices we use, can also expand chest walls at night and help minimize atelectasis in our SMA ones and help treat pectus excavatum. We want to compensate that when kids get sick, they get weaker, so they may need more support. So they may need a little extra help when they're asleep, when they have a bad cold or an infection. And ultimately, what we all want to do is optimize our children, our patients' quality of life and their comfort. We want it to be a life worth living, one that they're happy and enjoying themselves. We don't want to be doing so much therapy that we're not letting them sleep well. We want them to be able to wake up and enjoy their next day, that they can go to school, they can go to daycare, they can participate in family activities. So when do we initiate respiratory support? Well, usually when the FVC or forced vital capacity starts getting around 50 to 60% of predicted is when they're going to start needing support. So I'll usually for my older kids, get a baseline screening test around 50 to 60%. If we're seeing oxygen desaturations, especially while awake, or CO2 elevations while awake in clinic, that's a patient who's probably going to need some support at night. If we get a sleep study, if we do it that way, we're looking for airway obstructions, low O2s, high CO2s, rapid breathings, poor sleep architecture, suggesting fragmented sleep. All of these things would suggest poor quality sleep and that they're going to probably need some positive airway pressure at night to help them breathe better and be more comfortable and give their body the rest they need. Any signs or symptoms? Any of you who see a pulmonary, we're usually asking these questions. Is your sleep restless? Are you waking up a lot? Are you having trouble falling back asleep? Do you have headaches in the morning, which might suggest carbon dioxide elevation? Are you fading at the end of the day? One of the questions I always ask my families is, do they have a good energy level as the day goes on, or do they run out of steam? If they're getting really tired and they don't say, I'm tired at the end of the day, my muscles are tired, but I'm awake, my body's tired, that's okay. If they say, yeah, I'm dozing off, I'm really sleepy, and my muscles are tired, we may need to provide some support at night. So what is a sleep study? Well, this is a very happy volunteer who's hooked up with wires, and what you can immediately see from this picture is two things. One, that's a lot of wires on my kid's face, and two, that kid's asleep with a lot of wires on your face. Bottom line is, we can get this done. Pediatric sleep labs are adept at taking care of young children with sleep disorders, so we can get studies. We may not have the pristine, perfect studies that our adult colleagues get, but we're able to get the data needed to help guide and manage your child's health. This is a child who's getting a titration study, and they have BiPAP on, and you can see the child is asleep with a pressure device on their face, and they're doing okay. So in a sleep study, we look at EEG, EOG, and EMGs. The brain waves, the eye movements, and the muscles to help stage our sleep. We have nasal flow to look for obstructions and pressure transducers to look for obstructions. We have chest and abdominal wall motion to look to make sure you're breathing. Limb leads, not so important in our kids with SMA, but it is still part of the routine sleep study. Oxygen and carbon dioxide levels, ECG for heart wave activity, and then sometimes we'll do titrations with BiPAP or non-invasive positive pressure ventilation, which is like a ventilator delivering BiPAP. It's just a pump from our perspective to help titrate and find the right dose of pressure needed. What does a sleep study measure? Well, do we have obstructive apneas or hypopneas, which are partial obstructions? Are they hypoventilating? And what we see in these circles here is you see chest wall motion, but no flow. And then you can see oxygen desaturations here. So this is classic obstructive apnea. So we look for apneas or hypopneas or partial obstructions, low O2 or high CO2 levels, breathings that are out of sync, an elevated respiratory rate would suggest that they're having trouble breathing at night. And does things get worse in REM sleep? During REM sleep, your diaphragm keeps working, but the rest of your muscles are paralyzed. Has nothing to do with SMA. That's just normal sleep. But all of our sleep tends to be worse in REM sleep. If you're already having sleep problems from your SMA, it's going to get worse in REM sleep. So we want to make sure we capture that. What do you call it? Does my kid need a sleep study, or can I just start them on BiPAP? Well, it really depends on where you're at and what's going on with your kid. So if you're, in the old world, before we started newborn screening and starting to diagnose kids very early, if a patient with SMA1 presented it and they were asymptomatic at the time, they're probably going to need therapy, but I might have time to get a sleep study on them when we can discuss, do we want to go down that route with the family? But if they present to my pulmonary clinic in respiratory failure or respiratory distress, I'm going to get them on BiPAP immediately and go with empiric settings that we've developed with experience, that a lot of work based on stuff that Mary Stroke did back in the 90s and aughts. In our type 2s and 3s, we'll probably need a sleep study because usually that's not so emergent, but we'll get a sleep study to help make the diagnosis. And then we'll probably bring them in for a BiPAP titration study if that's possible. Otherwise, we'll go with empiric settings, make our best guess, and then we'll use the PAP downloads from the machine, pulse ox downloads, and carbon dioxide downloads if we can get it, to make sure that they're fine and tweak our settings accordingly. A lot depends if you have access to a sleep lab. Here in Durham, I'm lucky, I run the sleep lab. I've got access, I can get my kids in for sleep studies. But if I'm living in the middle of Montana, getting to a sleep lab may not be that practical. So I may need to do more empiric therapy. A lot depends on where you live and what your resources are. In general, a pediatric sleep lab is best for this stuff. If you're going to have it in a community adult lab, it can be done, but you want to make sure they have experience with neuromuscular and know what they're looking for. Standard adult sleep labs don't use CO2 monitoring. You got to ask for that. The titration studies, they really need to know how to titrate a neuromuscularly weak patient and not straightforward sleep apnea. It's not quite the same. A lot of parents say, hey, my husband had obstructive sleep apnea, he got a home sleep study, can my child have one? And the simple answer is no. Those studies are for very simple cases. For complicated neuromuscular patients, it's not going to give you good data. So the answer is no, they really need to be done in a sleep lab. Again, there's center-to-center practice variability and accessibility. And then also, the question we all hate is, what does the insurance company allow you to have? That sometimes guides what we're going to do. But there are ways around the insurance company, and just talk with your sleep doc or talk with your pulmonologist, and they'll help you get what you need. These are just some examples of equipment. In non-invasive, we have BiPAP, or we can use a ventilator. This is a standard BiPAP machine. This is a ventilator. This is the Trilogy. This is a Trilogy Evo, a newer version. In invasive ventilation, we can't use a BiPAP machine. We have to use a ventilator, but now it's delivered through a tracheostomy. And we have multiple different modes of ventilatory support we can use. Standard BiPAP, and then fancier modes like AVAPs or pressure control. And all of these are set with pressures and a rate to help rest your muscles. These are just slides of various types of interface. These are all nasal masks, and these are obviously tracheostomy tubes. What are the advantages of non-invasive ventilation? Well, first of all, it's non-invasive. You don't need to do any surgery. It's reversible. You don't like it, you take it off, you're done. It's safe, it's effective. It preserves our natural airway functions. The risk of infection is very low The risk of a infection with trach is low, but this is even lower. You can still talk with BiPAP in place. You can talk with the trach in place, but it might be a little more effort, require a little more effort. What are the disadvantages? Well, we can't suction the airway out as well as we can with a tracheostomy, but still, that's a small disadvantage. Sometimes kids will swallow a lot of air, which can make reflux worse. So a lot of times we adjust the pressures accordingly, use different types of interfaces to minimize this risk. Having a mask on your face, you can't see that child's beautiful face so easily. That's a disappointment. If too much pressure is placed on the face, it can cause facial bone remodeling. So you want to make sure the mask is the right fitting mask and it's on firm but not too tight. And it also requires cooperation with the patient. Now, the good news is we can get most kids to cooperate. Some kids are tough, but most kids with practice, they can get acclimated to the mask, acclimated to headgear, and they'll do fine. What they need is docs like me working with them to make sure the equipment is comfortable and effective, and parents like you who are cheerleaders are going, you can do this, you can do this. It's going to take a little effort, but we're going to get through this together as a family. It is possible. Some other mask-related issues just to be aware about. It does take time to get acclimated to the mask on your face and the headgear on. And if you are adults with sleep apnea can testify that you feel a lot better with your CPAP or BiPAP on, but it took you a little getting used to. So you want to make sure that you give them time for acclimation. That's why I want to start therapy sooner than later, before you absolutely need it. So you have that time to acclimate before you truly need the equipment. Watch for skin breakdown or pressure sores. There's sometimes positional issues regarding the equipment, and irritation or allergic reaction to plastics can sometimes happen. You want a good fitting mask. Nasal masks and nasal pillows are the best. Nasal masks go on your nose, like in those pictures I showed you. Nasal pillows are like cushioned prongs that go in your nose, similar to nasal cannula oxygen, but not quite the same. I don't like using full face masks because it blocks the whole oral face, and if the machine has a problem at night, the child can't pull the mask off. If you have a nasal mask or nasal pillows, if they have some problems, they can breathe through their mouth until help comes. Ideally, the only time I use face masks, full face masks, is if there's someone monitoring the child at night. So if a home duty nurse is there overnight, now we can use full face masks. Excuse me. If you can have more than one mask, that's great, because that way you're never using too much pressure on one point all the time. I have one young man with Duchenne who has 3 or 4 masks, one for when he's out during the day, one for when he's eating meals, and one for when he's asleep. And he just rotates them around, and it's great. He's never had any skin problems or breakdown issues. It's great. So you can usually get more than one mask. You just have to work with your DME company to get the right masks. A big problem we have is the headgear. The masks fit, but the headgear is too big or too small, and that adjusts the mask position. So we have issues with that. Sometimes we need people to adjust the mask. So if you're a good sewer, you can make the mask tighter. I'm sorry, if you're a good sewer, you can make the headgear tighter, or you can cut it and loosen it up. My main sleep tech makes a lot of headgear adjustments for some of our patients to get a comfortable one. But I don't have a Jackie everywhere, so you have to work with what you have in your community. Any sewing circle that can work for it, if you know that through your church or your religious facility or through your community center, are great people to reach out to for resources. Special pillows to help cushion the CPAP, or sorry, the BiPAP device can sometimes be used. Trachs are definitely another way to go if non-invasive is not working. If you just can't get the kid under control with non-invasive, then a trach may be needed. If the kid just really hates the non-invasive and they need support, a trach may be needed. Oral secretions sometimes. People live in communities where they don't have access to this equipment. So as a result, they have to, a trach is just safer. Lots of different options. Really, at the end of the day, it's what's right for the family. The trach does have certain advantages. It allows the child's face to be seen. It's more easily suctioned. You can get secretions out more easily. And since more nurses are trained with trachs than they are with non-invasive, it gives the parents the ability to go out and have a nice evening because they know their child's with a nurse who's well acclimated with this equipment. I've seen a lot of kids who use non-invasive continuously, and the parents are just afraid to go out or take the child out because of the what they perceive to be instability. Anything that we can do to improve quality of life for not just the patient, but the family is necessary. So last part of the talk I want to talk about is our new drugs. We have 3 new drugs out there, going back to Spinraza in 2016, and now more recently Risdiplam. That's now changing how we approach our patients with SMA, and in particular the sleep. The bottom line is we don't really know the answer yet. We don't have a lot of data, but it's case by case. So I do have kids that maybe I'm initiating therapy later than I might have before we had these agents, or I'm now starting to wean them off support because they're doing really well. Again, though, it's a case by case, family by family basis. So regarding initiating therapy, if I have a type 1 that comes in, they're picked up on newborn screening, they're really strong, and they've started their Zolgensma or their Spinraza like on day of life 5 or 7, they may be strong and might not need anything. So I don't necessarily start them on BiPAP, but I'm going to watch them like a hawk, and I'm going to have the families watch them closely. And if they do anything that doesn't look right, we're going to have a sleep study and possibly initiate therapy. If they come in pretty weak because they're a place where it's not picked up on newborn screen and they just are late diagnosis, probably going to need to initiate therapy. Same goes with types 2s and 3s. They present early in life, they get therapy, they may not need interventions. We might get a sleep study to monitor them, but they may be able to avoid BiPAP. If they're newly diagnosed but symptomatic, they're a late diagnosis, again, we may need to initiate therapy. Again, case by case basis. We're going to be using, though, a lot of sleep studies to help guide us going forward. What about weaning? A lot of families go, my kid's doing better. You think I can come off BiPAP? Well, maybe you can. For my SMA ones who are pretty strong but they're needing BiPAP, I don't know if they're going to come off, but they certainly might not need it every night, or maybe not the entire night, or maybe they only need it when they're sick, but not when well. But we're going to figure this out together, what your child needs. For our type 2s and 3s, if they're doing really well, there's a chance they may be able to come off support. We're going to do sleep studies, home pulse ox downloads, whatnot, to get a sense and make sure it's safe. But we can talk about this. This is something we couldn't talk about 5 years ago. And the fact that I'm having these conversations, to me, is just wonderful that we have options that we didn't have. But you got to always remember, all our kids get worse when they get a cold. So the kid may be doing fine when they're well. We got to watch out with that cold. They may need extra support at those times. Supplemental oxygen is not that support we choose. So what are the take-home message for these new meds? Well, we've got options. We don't have to initiate our SMA ones immediately with BiPAP. We maybe have the option of watching and waiting. For our kids who have mild sleep apnea and are doing really well, we may be able to de-escalate care, but it's case-by-case basis. Don't just stop. If your kid's doing great, wonderful. Don't just turn off the BiPAP. We've heard too many horror stories of kids gave back the BiPAP and something happened and they got sick and they wound up in the hospital. We don't want that for your families. Work with us and we'll do it together as a team to do it in a safe manner for your child. We're going to be using a lot of data, more sleep studies maybe than we used to. I do a lot of home pulse oximetry to monitor kids to make sure they're not desaturating at night. I don't really in Durham have access to capnography or measuring carbon dioxide, but if you can have that, it's more data, which means more information and better guidance. And remember, don't just focus on how you're doing when you're well, you got to focus on what you're doing when you're sick. Anyway, we're just about out of time, so I'll leave time for questions, but just take home points I want you to go home with. Just because you have SMA doesn't mean you can't get a good night's sleep. So that's just not the price of doing business. Your kids, whether they need positive airway pressure support or not, they should have a good night's sleep. Work with your pulmonary doctor, work with your neurologist, work with your team to make sure you get a good night's sleep. Let's optimize both the quantity and the quality of that sleep. Hold your child to the same standard you'd hold their siblings to. BiPAP, non-invasive ventilation, can optimize sleep quality. So when needed, let's use it. And then finally, we now have new therapies that give us more options than we ever had before. So before I could say, this is what you can expect and you're going to be using this the rest of your life. Now I don't say that anymore. I go, this is what you need. Let's take it day by day, visit by visit. And if we are doing well, we can look into de-escalating therapy. anyway, exciting time now for SMA, things that we never dreamed of, we hoped for 10 years ago, but now they're reality. So just as a reminder, there is a community social on Friday night. It's always a lot more fun in person, but we'll see you next year when we have it then. And I want to thank you for your time. And I would love to say this is the view I look outside my window. And I'd like to say I get into Cameron more often than I not, but I tell you, with Coach K retiring this year, I don't think I'm ever going to see the inside of that. Those tickets are going to be as good as gold. Anyway, everyone, thank you for your time, and I'll give it back to our monitor for questions.
Great. Thank you so much, Dr. Kravitz, for such a great and informative presentation today. We really appreciate you being here and sharing with the community today. So we do have just a few minutes for questions, and we'll go ahead and get started, Dr. Kravitz. Our first question that came in is, can you actually go back to the part where you're talking about extra secretions? Does adjusting pressures help with this, or is it just a common aspect of sleeping with a BiPAP and having SMA?
We do see secretions, going back a little more. Yeah. You can see more secretions with BiPAP, and what's happening a lot of times is you're pushing all that air in, and if you're having swallowing difficulties, and that all that positive air pushes your secretions out. So there are ways to work around that. So for example, maybe you need to have a ramp. So I can turn on the BiPAP machine and give you the pressure you need, or maybe I want to have a ramp so that you get your full pressures at a deeper level of sleep, and when you start to wake up, it can back down so that it's not constantly stimulating secretions. Or we can sometimes use drying agents, which in general we don't like to do, but for some of our patients we might need to use like a little atropine under the tongue or Robenol if secretions are a real issue. When they become problematic, that's now they're really choking on secretions and aspirating. If we can't manage that, then we maybe have to discuss tracheostomy. But I like to work with settings on the BiPAP machine, different mask interfaces before I give up on that. And usually we can get the secretion management, maybe not perfect, but manageable.
Great. Thank you so much for answering that and going back on those slides, Dr. Kravitz. Our next question is, how often do you recommend a sleep study for a child that uses a BiPAP?
That's a great question. And the simple answer is there is no answer. Okay. If I have a child on BiPAP and they're doing great, I don't necessarily do periodic follow-up studies to do it. They're expensive, they're labor intensive. Let's be honest, our kids don't like them. Parents don't like them. It's inconvenient, especially if you're not near a sleep lab. So I'll do other things. So I will get pulse ox downloads to make sure that oxygen saturations are being maintained normal. I will, if they have a PAP machine, I will get a PAP utilization effectiveness download to see if obstructions are occurring. It's not going to tell me my ventilation as well as I'd like, but it still gives me a ballpark figure. That being said, if I have you on a BiPAP setting and you're doing well, and then you start complaining that you're not sleeping well at night, you're waking up more, you're having morning headaches, if I can't make some I'll make some empiric tweaks to try and keep you out of the lab. I'll use these downloads, but if I'm not getting you what you need, then I'll bring you back in for a study to titrate. But I don't automatically do routine yearly, every other year sleep studies on patients unless their clinical situation warrants it.
Thank you so much, Dr. Kravitz, for answering that question. Our next question is, what would you suggest for dealing with pressure sores caused by the BiPAP mask?
Okay, excellent question. So first thing is, I always ask my patients that have regular sleep problems when they come in with their CPAP or BiPAP machine to bring every equipment. I like it when our neuromuscular patients can do that too. And what I'll do is I'll have my sleep technician or my respiratory therapist do a mask fitting and see what's going on. Is it a bad mask for you? Has your child's face grown and they need a new interface now? Is the headgear proper? There's many a time where the child has grown, and what used to be a good fit now isn't. So the parents are tightening the headgear more to get that mask to stay on, and that's causing pressure sores. So what we do is we change the mask around. Maybe I take the same type of mask, but get a bigger size, or maybe I go to a different type of interface. So bring the headgear, bring the mask to your doctor's office. There was a slide there of things you can use. Let me try it. Here we go. Like putting like moleskin on your face, different devices. You can put moleskin on the mask to make it more cushion. A lot of times it's not the mask, it's the headgear. So don't forget about that. It's just the headgear. And like I said, take it, if you know somebody who sews, or take up sewing, this is the way you can fix the headgear and adjust it. We have this many mask interfaces. You know, when Mary and I were working at like Cure SMA meetings 12, 13 years ago, there was this many mask interfaces. We have this many now. Unfortunately, we only have this many headgear. So a lot of times we have to fix that on the fly. But if you're having pressure sores, there's no reason. Bring it to the attention of your doc. They'll get the DME company to come out and work with you, or we'll bring the equipment to clinic and we'll work with you there with our respiratory therapists.
Wonderful. Thank you so much, Dr. Kravitz. Lots of questions coming in, so we'll keep going. Our next question. Are there suggestions on extinction methods for parents to get out of the room with crying, secretions, removing BiPAP during fits for a toddler?
That's a good question and a tough one. So here's the thing. If you can't get out of the room because there's so much secretions, the problem is not you getting out of the room. The problem is the secretions. So you got to go upstream, so to speak, and get with the secretions addressed. And that goes back to what I talked about earlier. Suctioning, are they refluxing? Do they have bad swallowing function? What can you do to help with that? As for, what was the second part of the question? I'm sorry.
It was suggestions on extinction methods for parents to get out of the room with crying, secretions, and removing the BiPAP during fits.
Okay. Well, you know, you have to be case by case basis. What I usually try and do is get the BiPAP equipment out to the families, like I said, before they absolutely need it, or where it's only very mild, so we have some time to get them acclimated. And I work with the families to try and get the kids acclimated while it's there, while it's awake. If they do it okay when they're awake, they're going to do a lot better when they're asleep. Just to come in out of the blue, put a mask on their face and walk out is not a setup for success, whether you have SMA or you don't have SMA. Adults, you can reason with them, you can talk. 2-year-olds, you're never going to win that battle. But you got to be firm, you got to be strong. Again, easier said than done. You want to make sure it's a good fitting mask so they're not crying because they are physically uncomfortable with the mask on. Ideally, you want to, you might just have to leave them with the mask on. If you know it's safe, you're monitoring them appropriately. You can be outside the room, but you want to be out there so they can fall asleep with you not in the room. But there's going to be some nights you're just going to have to say, this is not going to work. And no, when we do sleep studies, we have kids that are crying. What we might do is not put the mask on until they're in a deeper sleep. So remember I said earlier that stage 3 is that really deep sleep that's hard to wake up. That occurs maybe 45 minutes into sleep. So maybe what you do if you're really having a kid with a fit is let them fall asleep with the mask off, and about 30 to 45 minutes in, tiptoe into the room and gently try and put the mask on. You'll have more success than if they're fighting you at the start. But these are individualized questions. They're great ones, and believe me, I get a lot of them. But you work with your kid, you work with your docs, you work with your SMA team to come up with a solution that works. And it's trial and error to some extent. But in the end, most kids do okay if you persevere. Easier said than done, though.
Thank you, Dr. Kravitz. Our next question is, could sleeping too much during the night, roughly around 10 to 11 hours, cause more daytime tiredness?
That's an interesting question. The short answer is no. What I've found is that sometimes people get more sleep and then they say, you know, I used to get by on 6 hours of sleep and now I get 8 or 9. If I don't get 8 or 9, I'm miserable. So I liked it better when I got 6. Well, what it is your body got acclimated to getting the right amount of sleep. So you can't per se oversleep. Okay. Your body needs what your body needs. So if you're sitting there and getting 10, 12 hours and you feel better and that's what you need, that's what you need. Now, unfortunately, the way the world is, a lot of people have to, they don't prioritize sleep. They got too many things to do. I'm guilty of that myself. But as one of my partners who's a neurologist who does regular sleep medicine is, you value your nutrition, you value your exercise, you value your social life. You've got to value your sleep too. Get the sleep you need. You're not going to hurt yourself by sleeping too much. You're going to be more well rested and you're going to enjoy the time you're awake a lot more. I hope that answers that question.
Thank you, Dr. Kravitz. Appreciate it. I think we've got time for just one last question here. What age do you recommend stopping naps if there are night sleep issues? And do you think, kind of a two-part question, do you think naps benefit someone with SMA?
Well, here's the deal. Forget SMA. When babies are babies, they need 2 naps a day. And then they gradually on their own get rid of that morning nap. And I can tell you as a parent, boy, I love that morning nap. Got more done at home when she had 2 naps than 1. Eventually they'll get rid of the afternoon nap, but that's variable. Some kids get rid of it at 4 or 5 years old. Some kids are in kindergarten, even first grade, they're really tired. They still need a nap, but they should gradually outgrow it and consolidate their sleep at night. So if your child needs a nap, that's okay. The question is, if they didn't need a nap and now they start to need a nap, now I say, is your sleep good quality sleep? We have to assess that. I think that was one of the questions. The bottom line is naps are normal when you're a kid. When you're an adult, when you're a teenager, if you're falling asleep during the day, there's one of 2 reasons why you're doing it. You're not getting enough at night or it's poor quality. Okay, or both. And for a lot of our SMAs, it's all 3. So start needing naps. Let your docs know that they may need, first of all, a behavioral history to see what's going on. If I have a kid going to bed at 2 and waking up at 7, it doesn't matter if they snore or not. They're not getting enough sleep. They're going to be tired. So let's focus on the behavioral, get that addressed. And then while we're also focusing on getting the sleep better controlled. Okay.
Great. Thank you so much, Dr. Kravitz, for taking the time to answer all those questions. And again, thank you to everyone who joined in today and sent in the questions as well. You are able to still use the chat function on this session and ask questions throughout the conference, and we'd be happy to help pass those questions along. So again, thank you, Dr. Kravitz, for your time today and presentation.
All right, I look forward to seeing you all next year. Take care.
Thank you. And I did want to mention there is a survey linked in the session page, and you'll also be receiving a follow-up email with that survey link, and we welcome any feedback that you have to share. Once again, we are incredibly thankful for the support from our sponsors for really making the 2021 Virtual SMA Conference possible. And please be sure to join us this evening for the very first virtual exhibit hall, which is from 4 to 6 p.m. Central Time. You'll be able to check out all of the booths, see all the different products and services they have, interact and talk with the exhibitors and more. And also the more booths that you attend, the more times you are entered to win a prize, and we will be announcing the prize winners on the Friday closing session. So again, if there's anything that we can do, please always feel free to email us at familysupport@curesma.org. Thank you so much again, everyone. Have a great day, and thank you for joining us for the 2021 Virtual SMA Conference.